COVID-19 pandemic has left all of us overwhelmed. It not only halted our lives, but learning as well. But it's rightly said, where there's a will, there's a way. And what would be a better example than the year 2020 and 21, which has seen a tremendous surge in the unique learning opportunities in the form of online learning platforms. Online conferences, collaborations, and interactions with experts and peers all over the world has not only made learning global, but the world seems to be a smaller place now, just the size of your phones, tabs, and laptops. Jai Hind and a warm good morning to respected principals, sir, heads of all departments, faculty members, dear colleagues, and alumni who have joined us today, and my dear students. Today, I, Dr. Shikhar Jaiswal, on behalf of the Department of Conservative Dentistry and Endodontics, take the proud privilege to welcome you all to yet another program in the webinar series organized by Subharti Dental College and Hospital to celebrate 25 years of service and excellence. The year 2021 has been a tough one for all of us. We've lost three gems from Subharti family before beginning today's session. We would like to pay respect and homage to late Dr. Mukti Bhatnagar ma'am, founder of Subharti Group of Institutions, pillar of strength, heart and soul of Subharti, late Dr. B.P. Khattak sir, academician par excellence, the man behind the strong academic foundation of Subharti Dental College, and late Dr. Vishal Bansal sir, the fearless surgeon, head Department of Oral and Maxillofacial Surgery since last 9 years. They'll be remembered for the years of relentless service and contribution in this journey of Subharti Dental College. Many heartaches, but well, that's life, and as they say, the show must go on. Continuing with today's program, I would now like to invite Dr. Vinita Nikhil ma'am, Head, Department of Conservative Dentistry and Endodontics, to say a few words.
Jai Hind and a very blissful morning to respected Principal Sir, today's speaker, Dr. Videsh Chopra, my dear friends and my students. I welcome you all to a special webinar which we are organizing on the occasion of 25th Year of Excellence of Subharti Dental College. Friends, it has been the tradition of Subharti Dental College to organize such webinars and invite experts of different fields for enhancement of skill and knowledge. And when this expert is our own alumni, it is Soni Suhaga. Today's speaker is a role model and inspiration for many, and his area of interest is retreatment endodontics. I am very much sure that all of us will be beneficial by hearing his talk of today's. Thank you and Jai Hind.
Thank you so much, ma'am, for your kind words. One of the most commonly performed procedures in dental practice is root canal treatment, which is aimed towards preserving tooth and periodontium by eliminating pulp and periapical diseases. However, we often encounter cases of failed root canal treatment, and these deserve special treatment and require expertise. Today, we have amongst us a very own alumni, Dr. Videsh Chopra, who will enlighten us on this aspect. His topic is Failure is not the end of the world. Let's retreat basic concepts. I would now like to invite Dr. Navneet Kaur to introduce our guest speaker, Dr. Videsh Chopra.
Dr. Viresh sir has completed his graduation and post-graduation from Subharti Dental College. He served as a senior lecturer in Subharti till 2012, after which he moved to Oman. Currently, he is the lead for endodontology and senior lecturer in adult restorative dentistry at Oman Dental College, Muscat. Along with being the course lead, he is pursuing his PhD in clinical endodontics from Queen Mary University, London. Apart from this, he is an international editorial board member and reviewer in many national and international journals. He is also the editor of the book titled Clinical Atlas on Retreatment in Endodontics, published under the banner of Wiley Blackwell UK. He has many scientific paper publications to his credit. Sir is also a key opinion leader for leading dental companies such as Colteen and FKG, along with many others. His key areas of interest are CBCT, microscopic endodontics, retreatment in endodontics, and regeneration. Along with being a dental specialist, he has been an international player of fencing and has represented India in many Asian championships. He's an active sportsman and has played various district and state level tournaments in cricket and badminton. Reading books on philosophy and watching inspirational movies is amongst the few of his hobbies. So, we wholeheartedly welcome you, sir, and without any further delay, I request you to start the presentation.
A very good morning to everyone. First of all, I would like to thank ma'am for such a lovely and kind introduction. And secondly, I would like to take this opportunity to thank each and started to learn how to walk in dentistry. Um, Again and again, I'm saying thanks to each and everyone in Subharti who has played a major role in my career, in shaping up my career and shaping me as a professional and a human being. So I'm really thankful to all of you. And here I am. Very good morning to each and everyone. So today we'll be discussing about some basic concepts of retreatment, and I'll start by sharing my screen. Uh, Subharti, and also this is a great honor and indeed a privilege for me to be speaking on a platform where actually I started to learn how to walk in dentistry. Um, Again and again, I'm saying thanks to each and everyone in Subharti who has played a major role in my career, in shaping up my career. And be advising the patient. This is one of the topic that I really like in endodontics, and I really try to work more and more on it. Failure is not the end of the world. Let's retreat. Now, why I have chosen this topic is basically because I feel that once we leave our master's degree and we go into the professional world, sometimes I have seen that in private practice, clinicians get more inclined towards, extracting the tooth and putting more implants. Yes, it's an easier option, and probably it is really pocket friendly to many of the clinicians. No offense to anybody, it's our choice. But I feel somehow, as an endodontist, we have the right and we should be advising the patient that the best implant in the tooth, the best implant in the mouth is actually his own teeth. And if the tooth is restorable and if the tooth has a good prognosis, then definitely it should be given a chance by retreating it. Doesn't matter if it has failed once or even twice in the initial root canal treatments, but if we feel that there is one of the there are chances to save the tooth, then we should definitely go ahead with it. Recently, I have also published a book on retreatment in endodontics because I felt that there is a need of atlas on retreatment in endodontics, and this is just a small effort to do something in my profession. Probably, I feel it will be helpful to all the clinicians around the world, and it will be helpful to every dentist to relate the cases in their own clinics and probably get some guidance on it. So let's start with this topic. As you know that I am talking about failures here, but let's understand that what do we mean by failures? That what do we mean when we say it's a failure? What do we mean by that? Now, if it comes to me, I basically, whether it is in dentistry, whether it is in life, whenever I feel failures, and whenever I faced a lot of failures in life, uh, but what I have learned by walking on these path of failures is that failures are nothing but basically it's an opportunity to find an appropriate intelligent logic used to reach endodontic success. Now, if it's a failure in life or something, then probably you scrape off the word endodontics. But if we are talking in a professional way, then definitely we want to reach endodontic success and we want our treatment to be successful as well as give life to the tooth so that it can work for a good number of years or probably a lifetime, right? So consider failure as an opportunity where we need to find an appropriate intelligent logic that why it has failed, what is the reason behind it, and if we feel that the tooth has a good prognosis and has a good restorability, and the logic because of which it has failed, the reason because of which it has failed, we are able to overcome that reason, then basically we are on the right track. Now, when I say that there is a reason for it to fail, I don't want to sound as being emotional that get into emotions and just try to save each and everything. No, we have to be really practical into this because it's not about our feelings here as a professional endodontist, but it is also about the pocket of the patient and what is good for the patient at that point of time. So we have to be evidence based. We have to see what is the evidence we have in our hand to have that treatment option. And sometimes if we do not have enough evidence, that doesn't mean that we cannot go for that option. Just try to think out of the box and try to make your own ways, probably if they are in line with the patient's thought and patient is convinced for them, then only take a step forward. Now, when I am talking about failure, the basic aim of this presentation is not to discuss the steps or discuss the basic literature. Probably whoever is listening to this presentation is much and much more learned than me in this field, and you don't need the support of me showing literature or me telling that these steps you should follow. You are much better than what I am. So the basic aim of the presentation is basically that what I have learned while going through failures is just analyze those failures, that why it must have happened and how we can solve it. And when we think about how we can solve it, we can actually start imagining and develop. Sometimes we can develop our own ways. You know, yes, as I said, they should be evidence supported, but sometimes you might not get enough evidence. But however, even if you get one evidence regarding that, give it a try, and consider these mistakes to learn in future. These mistakes may be done by us, or may be done by any colleague of ours or associate dentist of ours. Doesn't matter, but take them as an opportunity to learn, to achieve success. So that is the basic aim. So the aim is, again, I'm saying, not here to showcase what is in literature, or to showcase that okay, these steps we have to follow. You probably, each one of you is much 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 better than what I am or what I was at that particular stage. So here I am to present a short movie on retreatment with support of some evidence, literature review through, and taking you through a journey of some failed root canal cases that have been treated successfully after analyzing the causes of failures. And there have been certain evidence-based treatment options for these failures. Now, when I'm saying evidence-based treatment options, I am not saying that what treatment you see on the screen is the best treatment available. Probably we can discuss through various treatment options in each and every case, but the treatment that has been showcased in this particular presentation, according to me as a clinician, I felt that at that point of time those treatment options are good for the patient. As a clinician, when the other person sees that particular tooth, he might also come up with a brilliant treatment option, which I must have overlooked or I did not get a chance to discuss about it. Now, when we go through the literature, we all know that these are various reasons because of which initial root canal treatment fail. These are the endodontic mishaps, which are very commonly shown in the literature, documented every now and then, and every retreatment article will definitely have these statements, these endodontic mishaps mentioned as the cause of failures. However, when we read those articles also say that these causes, these endodontic mishaps result in any inadequate cleaning and disinfection of the root canal system, which gives an opportunity to the microbial infection to grow. So there is a little gap, but I feel technically it would be actually wrong to say that the tooth failed because of perforation or a missed canal or under obturation or whatever is the reason out of these or out of the causes that are listed in literature. I would say technically, probably it is the inadequate cleaning and disinfection that has caused the failure because it gave an opportunity to microbial infection to grow. So now, coming back to the same slide here, if I say that if there was a perforation that had happened, is it that big a deal that perforation happened? Oh, now the tooth cannot be saved. What if we can close that perforation and we can create a microorganism friendly atmosphere there? I am not saying microorganism free atmosphere. You cannot, how much ever good we are, how much ever good cleaning and disinfection we do, we cannot, it has been proven that we cannot have 100% free microorganism free root canal. Some amount would be there, but that amount should be minimal enough so that it is not able to cause a microbial infection. So if you ask me, and whenever we have a discussion on this, probably I feel personally that technically failures in failures category should be because of inadequate cleaning and disinfection and not because of these mishaps. Now, when we say inadequate cleaning and shaping, or when we say these mishaps are responsible for failures, at the same time, we also read and we also say that good looking root canals also fail. So what has happened if the root canal is good looking? Everything is good in the root canal, no endodontic mishap is there, then why it has failed? So this means that inadequate cleaning and shaping, cleaning and disinfection plays an important role in deciding whether the teeth has to be termed as success in root canal or a failure in root canal. So here you see on the screen there is a good looking root canal in both the molars, but somehow it must have failed or it has failed. We will see in future slides, because somewhere we need to remember and appreciate the fact that it is not the root canal that we are treating. We are basically playing with the root canal system here. Root canal system comprise does not comprise of only three root canals, one or four root canals. It basically comprises of numerous branches and multi branchial system that we are encountering, and we have to go through these branches by our disinfection solutions with our instruments sometimes, and we have to clean as much as possible so that we create an environment where these small entities are not able to cause any discomfort or cause any failure on our treatment here. So we need to appreciate the fact that we are not looking into root canals here, but we are looking into root canal system here. This statement, basically, in one of my discussions with Dr. Martin Trope, it doesn't need this name doesn't need an introduction here. I actually stole this statement from him and I took his permission to share this statement in every presentation of mine, because it actually really made sense. Uh, and this statement says that nothing is possible in the presence of microorganisms. Yes, even if you do an excellent root canal, as we saw in the previous radiograph, if you do an excellent root canal treatment, still, if there is a presence of microorganisms in majority, which is able to cause failure, then it will fail, right? But everything is possible in the absence of microorganisms. Now, when we say in the absence of microorganisms, again, I am repeating that it is practically not possible to have a complete absence of microorganisms from the root canal system. However, the aim of cleaning and disinfection and doing the root canal treatment is to decrease the quantity of microorganisms, the count of microorganisms to such an extent that the healing mechanism of the body is able to overpower the infection stamina of the microorganisms, and then we are able to have success, or we are able to appreciate significant healing in the coming radiographs if the tooth is suffering from periapical healing here. Now, endodentistry, when we talk about endo basically means that we are having emerging devices, newer devices. Every now and then we know that in endo, so many companies are there. They are just advertising today this device, today that device, this material, that material has come, and so that we are able to do better dentistry. Now, when we say newer devices, then we should be careful, because many of our colleagues, they probably feel that all these devices are very expensive, very so dentistry is a very costly deal. It is not like that. The market is vast these days, and you have every version available according to your pocket. But the important point is to realize that we need to start somewhere. For example, if we talk about magnification doesn't only mean microscopes. Magnification also mean that you can at least start from loop, so that you can play around in excess cavities, you can play around in perforation in excess cavities, or you can actually play around in coronal part of the root canal system also. you know so it is important to give it a start, rather than sitting back and just thinking that new devices are there. Like for example, bioceramics are there. Bioceramics is a costly material, but definitely if it is required in a patient, you have multi varieties of bioceramics. At least we can start from somewhere to and have a pocket friendly bioceramic to see its effect in that particular case, if the case requires it. So it is important to give a start, right? So endo itself means that all every day there are new emerging devices and materials which help us to obtain success and give us a idea. However, even we have the best devices, we have magnification, we need to appreciate the fact that the medical field is like a slippery terrain we are walking on, right? And every time we fail, every time we encounter a challenge, every time we encounter a surprise when we open a tooth or a human body, we need to respect the fact that how poorly we understand them, because every tooth you open will give something new to you. Try to look it into under magnification. Definitely sometimes the even if there are it's a maxillary molar and we are opening a maxillary molar, first molar, it has three canals only, but somehow when you see the tooth under microscope, you will realize that the palatal configuration, palatal shape of the root canal, or the grooves running inside the root canal, it's like tells us that how poorly we understand them, how poorly we understand, even for that matter, how poorly we understand pulpal tags. You see under magnification, you do a palatal canal in a maxillary molar, and after that in the grooves you will see these pulpal tags, and then we understand that what we have actually read in literature is that these small tissue tags are able to cause discomfort to the patient. And sometimes I, as a master student, I always used to wonder what this professor is speaking, or what this teacher is speaking. How can this small tissue tag cause a problem? But now when I am seeing them live under microscope, I really appreciate the fact that, and I respect those teachers that who tried to make me learn at that point of time. But me as a student, as many of the students listening to this presentation, we have a different bent of mind at that point of time, and we feel we know everything, but actually we know very little. Right. So again, respect to all the teachers who have actually tried to, who always try to make us a better professional. Now, coming on to this article, which was basically published in 2011, which analyzed the cause of failure in non-surgical treatment by microscopic infection during endodontic microsurgery. And it clearly stated actually the reasons for root canal failures, right? And we all know that it is very common, and it is again and again documented that missing canals or leaky canals. Leaky canal basically cover the category where, the apical seal is not good. Not only apical seal, but apical seal or coronal seal is not good, or the quality of obturation is not good. So basically, leaky canal is a vast is an umbrella which actually covers all these factors where which lead to micro leakage in the root canal system. It might be due to some endodontic mishaps also, right? So it again and again shows that missing canal has been the number one factor, and followed by a leaky canal here. Now, if you see this case, this patient came with a complaint of pain in maxillary molar. Root canals were done within a period of 1 year, 1 and 2 years, because the patient had four root canals in a row. So probably she did not remember that when which was done when. So she gave a vague idea that it was done around 2 to 3 years ago, 1 or 2 or 2 to 3 years ago. And then the complaint of the patient was that tenderness to eating while eating is there on maxillary molar. Clinically, when we checked, yes, there was tenderness to percussion. And another symptom that the patient gave was that whenever she is having cold, not every time, but sometimes she feels a sudden sensation on this particular tooth. Repeatedly asked 2 or 3 times that in this particular tooth, she said, yes, the root canal looks to be really decent. When the patient came, I somehow, as a clinician, my vision directly concentration went on the premolar, second premolar, because it was an obvious short root canal. Right. So I again and again tapped on the second premolar, and she kept on saying, Doctor, no, I do not have a problem in this particular tooth. I have a problem in the tooth behind it. Right. So, okay, when the patient says, then we have to verify that again and again before proceeding with the next step. Now, another thing came to my mind was, which was actually interesting, and it might not go with the literature, but as I said, that if I have to verify myself and I know that it's not causing any harm to the patient, then definitely I'll try to convince the patient and try to do that particular thing, especially when it is not an invasive thing and I consider it as an investigation, right? So what I did here was, again, I am saying it might not be applicable according to you, but it gave me a good result. That is why I thought of doing it. Patient had said that when I drink cold, many a times I feel that sudden sensation is there. So I tried applying cold here. Right. I tried to do a cold testing, yes, on a root canal treated teeth, but since the patient was giving me a symptom, and I repeatedly asked her that for the past, whenever you got this treatment done 1 or 2 years, you're feeling that, yes, doctor, sometimes I do feel, and that is the discomfort I am having. And to my surprise, when I applied cold, she gave me a response there, you know. And the moment she gave me a response, it just came to my mind that maybe there is a missed canal and a maxillary molar. I referred for a CBCT. Somehow I could not upload CBCT in this presentation because the file got corrupted. But CBCT clearly showed me that there is a presence of fourth canal. Now, after this, the decision I had to make was how to go for the retreatment in this particular tooth. Now, what we can decide for a retreatment here is, we have two options here. Either we go for a complete retreatment of this particular tooth, or we go for a selective root canal retreatment in this particular tooth. After seeing the CBCT, somehow I was convinced that there is a missed canal and I should be going for a selective root canal treatment. That was what I decided, right? So because the quality of obturation, quality of apical seal and coronal seal really looked good to me. So I felt not to disturb that, and then started with a selective root canal treatment. And patient was made aware of it, that in case we need to remove the whole filling and do the retreatment for the whole tooth, we will go for it, but we will start with this because it is minimally invasive, right? So made a minimally invasive excess cavity around the mesial canal and tried to locate the missed canal there. Lucky enough, fortunate enough to find the missed canal and find a catch there with my DG16 Explorer. We should be really conservative before we step invasively inside, right? So we should check each and every step. That is what I follow in my practice. Once I saw the canal, saw the catch, tried placing 10K file loose enough, so I took a liberty of putting a 15K file and shot a radiograph and verified it on the radiograph. At the same time, clinically also, the file was verified, so that sometimes, the MB2 canal is really close to the MB1, and it might be meeting, or it might be, one canal with a very thin gap between the two. Sometimes GPs, you can see GPs meeting or getting mark on each other. So I checked my clinically, the file was checked so that there is no mark of a sealer or a GP getting scraped off. Once it was confirmed, the MB2 canal was confirmed, a regular cleaning and shaping protocol was done for the MB2 canal. Need not I need not explain the cleaning and shaping protocol because we all are masters of cleaning and shaping here. So regular cleaning and shaping, only thing was lubricant was used thoroughly, irrigation was used thoroughly, and no force was used, no active cleaning and shaping to be done, as we all follow, and only passive cleaning shaping to be done. Just follow the steps, just follow the protocol, and the life is simple while performing root canal treatment, right? So it's always good to keep things in a very simple way, in a very clear way, rather than complicating unnecessarily by thoughts or by evidences, something like that. So it just cleaning was done here, applied bioceramic sealers, because personally I really love bioceramic sealers. One is because of the ease of application. Second is because of their bioactive properties. Third is mess-free endodontics. So ease of application comes into that. Bioceramic sealer was applied, GP was placed, and obturation was done. Once this was done, patient became totally asymptomatic, totally free of any symptoms, and the patient basically till now is asymptomatic and happy. Another category is where you do not have very obvious root canals, but a clear inspection of the excess cavity really helps you at every step. And this is a perfect example of that. Had this excess cavity, or had another look was not given into this root canals, then probably anybody on this planet would miss this canal, and we would land up into another failure of another root canal retreatment done on this particular tooth. Root canal done around 6 months back. We can appreciate two canals, but somehow they look to be short of the apex. Decision had to be made whether to go through the crown or remove the crown. Uh, in a good scenario, taking out the crown and then doing a root canal retreatment is a very good option and should be followed. But sometimes patient doesn't want to remove the ceramic crowns, and because of the finances, and in that case basically it's best to tell the patient that it will be attempted. We can attempt that, but however, there are pros and cons. Crown can be debonded. One, since it's a ceramic crown, it can fracture under ultrasonic force vibrations of the instrument. So these all things, facts should be clear to the patient. If the patient understands, well and good. Otherwise, give a choice of only removing the crown. However, this patient understood the pros and cons, and we decided to go through the crown using of ultrasonic tips. The first and foremost thing in a retreatment step is, once you regain excess cavity, when you regain excess in the endodontic cavity, look for gutta perchas, because we do not have any dentinal map very obvious there, because it might be covered by gutta perchas. So gutta perchas are the indicator which will help us to play in the excess cavity and find our way to different canals. So once you get a gutta percha, then just play around and find the link between the canals through that particular gutta percha, and then you can just find your canals very easily. No need to touch the floor there and struggle while finding the canal. Once the gutta perchas are found, they can be taken out with whatever retreatment instruments you prefer. I am using here an endo shaper because I really love the design of it, and basically I am very comfortable with the fact the way it throws the gutta perchas out because of its spiral three-dimensional design. Right. So once they are removed, instrument, it is a straightforward cleaning shaping protocol to be followed, disinfection to be done. Straightforward case of retreatment. The intracanal medicament is placed, uh, and then the patient is recalled for the next visit where master cone try-in has been done. Once the master cone try-in done, a good look in the root canals was taken, and immediately gutta percha along the wall of the buccal canal was seen. Inner wall of the buccal canal was seen, and suddenly I checked my gutta perchas, master cone gutta perchas, and they were really smooth, and I could not see any abrasions there. So I was really wondering from where this gutta percha has come. So advantage of microscope here, and advantage of getting a chance to relook into the excess root canal. It was, since it was the inner wall, I used my DG16 probe to just scrape it off the wall so that then it comes out of with the irrigation, but it refused to scrape off from the walls. So once it refused to scrape off of the walls, it really struck the mind that why the hell it is stuck. It is stuck somewhere, so there must be a reason. Let me do the widen the orifice a little and see more inside what is happening. So ultrasonic tips were used here because they give an advantage of vision under magnification, and at the same time specificity is maintained. If I want to touch a particular point in an excess cavity, I'll be touching only that particular point, and I don't need to just make my assumptions and put the whole bar inside and just bring a tornado of cutting there. So I will be very specific. So ultrasonics is a good way of limiting yourself. The moment I use ultrasonics, this is what we saw inside. Extra canal there, gutta percha was taken out. The question was how to access this extra canal, because in the beginning it was smooth. And this thing I personally do in my clinical practice whenever I have a case where the canals are not very much accessible to me. Rather than using hand with my files, fingers on my files, I hold the files with locking tweezers, pre-curve my file, and keep the tip towards the direction of the canal I want to access at that point of time, and then take the file there and leave my tweezers there. Right. It helps me in having magnification. It helps in having a clear vision where the tip of the file is going, and it gives me a stress-free environment. Right. So once this is done, I place different files. You can see an H file, a K file, and a rotary file. for my convenience, because sometimes I do not know, I really do not know about everybody, but I get confused that which canal is a which canal, then sit there, take an angulation, or you put a slob rule. Who has so much of time of doing all these things in our private practice? So it's better to keep your life simple, put different files, so that it's easy to make decisions, and faster to make decisions. Once it is done, like a normal tooth, obturate it, every canal one by one, and do a warm vertical condensation, or whichever technique you are following. Do that particular technique and create a stress-free and a mess-free endodontic environment while working, so that it gives you a result of a clean work, and the job is done, patient is comfortable. Now, when traditionally we are making an excess cavity, we all know we need to start with a round burr and then wait for the drop to happen. In every, basically every excess cavity, we have to follow these guidelines. Once we follow the drop, we should understand that that is the end of our vertical cutting towards the pulp. Now, if we know that from now we do not have to do any vertical cutting here below, and we have to do lateral cutting only, then there is no chance that we will be going deep and touching the floor. And if we do not touch the floor, we are not hampering the dentinal map, the isthmus area. There is no chance that we will do a pulpal floor perforation. What is important is to realize that what is the depth where we felt the drop. Now, that depth can be different in different teeth depending upon the width of the pulp chamber, the dimensions of the pulp chamber, calcifications present, pulpal stones present. So we all have to take these into consideration while clinically treating the patients. Once we know the depth, then if we learn how to control the depth and where to control the depth, whichever burr in the world you use. I use proso or tapered burrs to make an excess cavity, and I've never, felt the need at this point of time to change my burrs. In the beginning, yes, I used to, but if we follow these guidelines and we know where to limit ourselves, actually, we will not feel the need of changing the burrs or changing the armamentarium in that particular excess cavity preparation. Traditionally, what we do is we go down, feel a drop, raise the burr, because once we feel a drop, it certainly falls down and touches the floor many a times. So it's a good idea to raise 0.5 mm and do a lateral cutting and finishing of the axial walls. Once these axial walls have been finished and we know the periphery of the excess cavity, that is when we know that the canals are present inside this excess cavity only. So we use our DG16 Explorer, find a catch, take a file, and verify the root canals. It's very straightforward and simple steps that we have to do. But what happens when we find we are not able to locate the canal? When we are not able to locate the canal, we panic. We use the same burr, go a little deeper, jiggle around the burr, and then again we go little more deeper when we are not able to find the catch, and that is when we go in different directions with our burrs, and that is when sometimes frustration takes over us, and sometimes we are not able to understand the anatomy, and then the bird goes in all possible directions, whichever is possible, so that perforations happen. So it's a very good idea to know the depth up to which you have to bring your bird down. In my masters, when I was doing, I used to mark my burrs, and there is no offense, no reason to feel offended here, and there is no shame in this, that oh, you used to mark your burrs, we can control our, it's not a proud feeling, it's nothing to feel proud of. If we need to mark our burrs, we need to mark our burrs. It will help us. So after 2-3 years of experience, or after 20 or 30 cases when we have done, we will not feel the need of marking our burr. At the same time, we will have a good control over our hand. So once it is done, the life becomes simple. then for the following years we can be do without marking the burrs or taking precautions. Otherwise, the result is this: we can have these sorts of perforations happening where the whole tissue is visible. And I was lucky enough to see this heartbeat sort of a thing, pulsating tissue in a perforation site right in the middle of a mandibular molar. Unfortunate, but yes, I really like this site, and I felt really privileged to have this opportunity to see this perforation. Or something like this can happen where canals are shaped and everything, but still we have a large perforation. Now, one of the cases, which is probably an endodontic stream having different kind of endodontic mishaps in a single case, root canal done around 2 years back, suspected pulpal floor perforation, suspected instrument fracture, missed canals, short obturation, maybe because of ledge or a calcified canal. We really do not know. We have to verify all these. So we tell the patient that the prognosis is not very good, but since the patient is young and he really wishes to save the tooth, and he says that I've already put so much of money into it, there is no harm in giving it a last try. So once here also it is not done, then we will extract the tooth. So patient has been convinced, consent form has been signed from the patient. Patient has a distal occlusion uh, restoration here, which is in basically in two parts. You can see here it has a, occlusal composite restoration and probably another material on the proximal side. Traditional endodontic excess cavity is started in a triangular form, trying to locate the gutta perchas. As I say, the moment the gutta perchas are located, there is a pinkish discoloration that is seen on the pulpal floor, evident of a perforation which we suspected in the periapical radiograph. Once the GPs are removed from the buccal canal, the pulpal floor, the radiograph is taken, and it is seen that actually palatal canal has not been touched at all. There is nothing on the palatal canal, and the distal buccal canal had a fractured instrument. Intracanal medicament is placed, perforation is cleaned and ready for getting sealed. The canals are blocked with gutta percha, temporarily blocked with gutta percha, and MTA is used to seal the perforation. Now, whenever we are using MTA, my personal preference is that I just throw the pellet of MTA there and then condense it lightly, passively with the plugger. We do not really need to bring the MTA gun very close to the tissue and shoot it so that it goes beyond. We really do not need it. It is good. It's a bioactive material and no harm to the periradicular tissues. It's good even if it is of no harm even if it goes beyond. But do we really need it? So once we don't need something, why not try to avoid it, right? So if it still it goes, it goes. So gently press it and try to get a apical seal. Oh, sorry, try to get a good seal around the perforation area. Once this is done, sorry, once this is done, micro brush is used, a little moisture to be placed so that it helps in hydration of the material. This is placed, and when the patient comes the next time, once we are going again with the ultrasonics inside, the proximal part of the restoration also falls off. So once this restoration falls off, suddenly we see another red area below, which is a palatal perforation. Now, if we go back to the radiograph that I had taken after the buccal canal GP removal, the palatal canal was not touched. So what came to the mind was that during the trying attempt to locate the palatal canal, this perforation might have happened. So again, the appointment was scheduled for location of palatal canal and cleaning and shaping of other canals. But then the concentration went on this perforation, and the total schedule of the appointment changed, and we had to do a MTA closure of the perforation site. But then, before touching the perforation with the MTA, it was decided to just locate the palatal canal once and then go with MTA, because if we place MTA before, then there would be, you know, moisture coming, then there would be vibrations for the this thing, though we could have done in another appointment. But then this was just thought that okay, we can make use of the same appointment, find a palatal canal. Once palatal canal is found, close with MTA, and then recall the patient and then do cleaning and disinfect. That sounded to be a better option at this point of time. So attempt to find the palatal canal was done with ultrasonics, taking care that pulpal floor is not touched because we have MTA below, and the proximal side is not touched because we have a perforation there. So, as I said, magnification and then use of smaller instruments gives you a specificity where you have to, touch your instruments, and you do not have to just go with your assumptions and try to cut everywhere. Once palatal canal was located, again the same protocol was followed. After MTA next visit, patient came, canals were again blocked, and the MTA was protected by glass ionomer cement, because more than 70 to 80% of the floor was MTA only. So it was decided to flow glass ionomer so that it can provide additional support to the MTA and we do not hamper it while doing the cleaning and shaping protocol. Once it was done, the root canal was treated like any normal tooth. Root cleaning and shaping was done. It was decided not to remove the instrument from the canal because it was fractured at the apical site, and the patient actually was becoming asymptomatic. All his signs and symptoms were going off. Tenderness went, the sinus with which intraoral swelling and sinus with which he had come totally went off. So he was comfortable, and if we had attempted to remove this instrument, probably it would have done more damage to the apical part of the canal rather than being beneficial. Attempts to bypass the instrument were done, but however, I did not succeed in bypassing the instrument, and I really did not want to, keep trying and just causing a strip perforation or something. So it was decided to leave the instrument there, and we will have keep it under recall, finish the root canals. This is the pre-op. Recall in a retreatment case is really important. You can see the root canals have been completely filled with sealer flowing everywhere actually, right? And the furcation healing is there. You can see a recall radiographs here. Now, once we have to decide for retreatment, if we see the excess cavities here, uh, we need to follow the laws of excess cavities, and one of the laws of excess cavity says that if you see the axial wall, the enamel, dentine, and pulpal floor junction should be in one line. So if that particular law we follow and it goes everywhere, it goes in one line, then probably we need not to worry about extra canal because all the canals are present in this particular room. So we need not take the first step as location of the canal. The first step should always be make a good excess cavity, right? Once the boundary of the excess cavity is decided, then within that boundary we can actually go and play around and look for our extra canals with DG16 Explorer, extra canals or the remaining canals with DG16 Explorer, so that we do not touch the isthmus with our burr, which is not actually required. So locating the all the canals in an excess cavity is actually the second step. First step is to have a boundary of periphery of excess cavity. Once the periphery is decided, then we can actually go. So the maximum time, probably not the maximum time, but try to spend as much as good time in preparing a good excess cavity, a straight line excess cavity, which provides ease for our vision, for our instruments, and for our cleaning and shaping protocol. Once the excess cavities have been located, once the root canals have been located, orifices have been located, then it is a good idea to widen the orifice, but it is a bad idea to force your instruments to widen those orifices. Simple is either you use a GG drill or we can use a SX file, orifice shapers, which comes in rotary files, but in wet canals and not in dry canals. So once you are doing them gently, you will open the excess cavity, open the orifice, and give a wider entering gate for your root canal files or root canal instruments to enter. Just we should be careful that let the file do the work and no need to force the instrument. Once the excess cavity is done, it gives an opportunity for the irrigant, for the debris, for the needle to feel free and come out of the orifice, so that we do not struggle and the needle doesn't get stuck again and again there. So there is no stress for the instrument once the orifice widening is done. Space for irrigant and debris to flush back is there. We all know. I really don't need to repeat these facts. But the only another advantage I found was easier location of the orifices on the recall visits. Yes, that when immediately we take out the cotton pallet after temporary cement removal, the canals are directly there in front of us. So it is another advantage according to me, which is a big clinical advantage in complex cases when you are handling. However, if we do not have a straight line access, which is of prime importance while doing rotary endodontics, if we do not have a straight line access, endodontic mishaps like instrument fractures are bound to happen. And once they happen, it becomes really difficult to negotiate the apical part of the canal. Yes, we know that it depends at what point of time they have fractured. They can be left inside and blah blah blah. So, but the thing is, why it should happen at the very first point. See, the reason that it should not be happening. So, if the instruments are old, we should change the instruments. If straight line access is not there, we should be having a straight line access. Once this has happened, then either we have a choice to bypass or we have a choice to remove the instrument. If a case if a case like this comes, then probably take working length in the remaining of the canals. We need a tool which is called as magnification loop, or not a loop, probably loop can help you to see instruments probably in the coronal part of the canal. But if you have to go in middle and the pike part, then probably you need a microscope to have a look. Now, here we need some treatment planning to be done. We cannot enlarge the whole canal and we should not be enlarging the whole canal. So we need to see the surfaces where your instrument is stuck. Now, in this particular case, the instrument is stuck in the inner wall, right? So the inner wall has to be widened. The instrument has to be freed from the inner wall. So there is actually no need of us touching the outer wall of the or the proximal wall of the root canal. So inner wall needs to be checked, which is towards the isthmus, towards the dentinal map. So inner wall needs to be widened, and we should widen it and release the instrument. Once we are doing this process, and the moment the instrument gets released from that one particular stuck point from the inner wall, it becomes loose and it can be easily held with the help of instrument loops and taken out very easily. Even if we are not using instrument loops, a little more vibration with irrigant, it can pop out the instrument outside the canal. And if we see here in this clinical diagram, only clinical picture, only the inner wall has been touched and there is no touching on the outer wall that has been done. Once this is done, the tooth becomes totally like a normal tooth, cleaning and shaping to be done, and followed by obturation. If you see the post-operative radiograph, Not no widening of the apical part, no widening of the middle part has been done to excessively to release the instrument and gain access to the instrument. All thanks to the ultrasonic tips present, all thanks to the magnification present. Now, if you are doing a curved canal, excess cavity has been done, location has been done, canals have been located, widening has been done. But if in a curved canal you are forcing a straight instrument, then you are bound to face a challenge of creating not creating an endodontic mishap, which probably many times doesn't happen, and we end up causing perforation. First, it starts with ledge, but since we cannot see anything in the apical part of the canal, we keep forcing our instrument, and actually, that instrument just cuts the dentine and goes and causes a strip perforation. So, pre-curving a file is a very good idea. The file should be pre-curved, but at the same time, it should be taken care that we do not rotate the file inside the canal. If you see the movements in this video, they are quarter turns that are given. Once these quarter turns are given, you will be able to negotiate the canal easily. Another advice here is do not try to negotiate a dry canal. Always wet the canal, even if with 2 drops of sodium hypochlorite or irrigant or even saline you want to use. Just wet the canal and then try to slide your instrument inside the canal, and you will see the difference that how easy it becomes in the presence of liquid inside the root canal. Once this is done, pre-curving is done, negotiation becomes really easy. And then once it is negotiated, then it can be slowly and steadily enlarged to a safer number. And then we can use rotary files and then do the cleaning and shaping. Advantage of pre-curving the file is not only having a negotiating curved canals, but at the same time, it is advantageous that it gives us a chance or an opportunity to scout lateral canals. Sometimes, if the lateral canals are big, sometimes it gives us a opportunity to scout lateral canals or even the communication ramifications between two canals. It becomes easier because the curved part of the instrument basically turns in 360 degrees. It will turn in 360 degrees once you rotate the instrument. If you are rotating a straight point, instrument will rotate, but at the same point, so it doesn't do any good to us, right? So it is better to pre-curve the file depending upon what your pre-operative radiograph is showing. According to that, you can decide on degree of curvature, but slightly, definitely pre-curve even when you are negotiating a straight canal. Endodontic ultrasonics is a very good idea to be used because, as I said in my previous slides, it gives you a specificity where you want to touch it, and with it provides you with efficiency also because you are not enlarging the excess cavity. You are having a good vision, even if you are using magnifying loops and not a microscope. It is giving you a good vision, and you can just cut in that particular area, and rest of the excess cavity remains really good. In terms of retreatment, when you are doing, gutta perchas are easily removed on from the pulpal floor, which actually should not be having any gutta perchas, but many a times we see clinicians leave lot of gutta perchas on the pulpal floor. The ideal place for the gutta percha to end coronally is your orifice, the opening of the orifice. But sometimes you see cases like these where a lot of gutta percha is just pressed inside the pulp chamber. So it helps us to produce heat and slowly remove gutta perchas there. Even if you do not have a the endodontic ultrasonics, you can use perio ultrasonics for this purpose. It is really helpful. Sometimes the coronal part of the root post can also be unscrewed using ultrasonics, even perio ultrasonics. I know if perio people might be hating me, but yes, They and thanks to you guys, these ultrasonics proved to be helpful to us in the absence of endo ultrasonic tips. Also, they help in minimally enlarging the excess cavities and facilitating the removal of a bulky pulp from the root canal walls. Yes, it can be removed with the help of root canal files or other endodontic explorers. But if you have to enlarge the cavity for some reason to meet the proper periphery, then it will you can do actually two works at one point of time, enlarging the cavity and at the same time removing the pulp from the chamber so that you get a good excess cavity with a good peripheral boundary. Now, the endodontic mishaps do not only happen while doing the root canal treatment, sometimes they happen while creating a post phase. Ideal, the drill should follow the gutta perchas. We actually, when we are using the gutta perchas, when we are using the drills to remove gutta percha, it is very, if we have a good tactile sensation. I know in low speed it is difficult to have tactile sensation, but when we are cutting gutta percha, due to heat, they become a little soft, and our drill will slightly follow the path very easily, and it will slide. However, if gutta perchas are hard, then also there is a difference between the resistance that you feel while cutting dentine and while cutting a gutta percha because of the nature of the material you are handling, because of the physical properties, right? So the dentine is very hard. So in case while drilling the tooth, we feel powder is coming out and gutta perchas are not coming out. Kindly recheck again so that we are in the, it's a good idea to recheck so that we know that we are in the same line as of the root canal and not going in any different direction, which will lead to a perforation. It is very easy to create a perforation while making a pore space. So it's a good idea to recheck rather than causing any disaster like it happened in this tooth. It was referred for a root canal treatment, completed the root canal treatment with three mesial canals, two distal canals, and referred back to the dentist for post-space preparation and restorability with post-endodontic full coverage restoration. Now, I strictly work in as an endodontist, and basically I work only for root canals and retreatments. I am not a restorative dentist, and I generally send the patients for restorations and post endodontic coverage restorations. I refer the patients to the specialist in that particular field. So once this post was given, the dentist, the colleague, he called me and he said, I can see blood inside the canal. When he said, I said, refer the patient back with the radiograph. This was the radiograph that he had sent me. I had a look clinically, dried the tooth. It's a good idea to use paper points here and not to use intracanal suction tips, because that suction pressure might attract more capillary fluid. So blood would be there. More blood. You should expect more blood if you are using intracanal suction tips, which I basically did not use in this case. I preferred using paper points. Once the area was dry, this was the tissue which had grown inside. Obviously, we have to place MTA, and as I said, the MTA gun was used, and as I said, that I prefer throwing the pallet there rather than pressing the pallet on the perforation side. I just throw and I then pass with a passive pressure. I use endodontic pluggers to condense the MTA in that particular area. Another pallet has to go inside after drying excessive moisture. Another pallet has to go inside. Gently place the pallet there. condense it so that you are able to seal the perforation site. The moment you seal the perforation site, the area becomes free of blood and is becomes, moves towards more safety. Verify on a radiograph, angulation of the radiograph previously, angulation of the post now. Sorry, angulation of the post previously and angulation of the post now. Job is done. Recall here, you can see good healing of the radicular lesion that had happened adjacent to perforation site. Very sorry. Now, it must have been now very clear that success in clinical endodontics basically does not depend upon only how you work or what armamentarium you have. That is not the only factor. You might be having the best of the instrument, but if you do not see clinical endodontics or see patient and create a good treatment plan for the patient, then probably it is not a good idea to consider that we can do magic with only advanced tools here, right? So success in clinical endodontics basically is a multifactorial thing which depends upon case selection, because we are not here to do any herodontics here. We are here to do good work, quality work, and take our profession to a different height with increasing quality with every patient. So case selection is really important, which should be evidence based, and sometimes yes, your gut feeling does play a role, but it should be beneficial for the patient and not beneficial for only our own pocket, right? Operator skill, we should respect the fact that how much skillful we are. I have no shame in saying that like I said, that I do retreatment and root canal treatment. I don't do restorations. I refer the patient. There is no harm in referring the patient. Uh, I seriously believe that if we can, as a teamwork, we can actually improvise on the quality if we know our limits and we do not think that we know everything in dentistry and in my own private practice I'm the king of the practice and nobody is better than me. Probably that is the wrong way of dealing with our profession and ourselves also. So it's important to know the limit of our skills. What is our justification to save the tooth? That are we justified in saving the tooth and we are not in a dream world and we are not getting emotional in saving the tooth, and later we feel disaster because it involves a lot of money from the patient. Retreatment basically costs more money. Magnification, yes, as I said, there are different levels of magnification. We do not need to see directly the microscopes. We can start with loops also. How much patient is motivated, because lot of role is played by patient's motivation. Sometimes patients will come and just say that extract the tooth. It's okay. If you hit your head with such patients, sometimes if you fail, then they can be a pain, right? So it's better to decide there and then. If patient really looks to be motivated, then go for saving the tooth if you feel it can be saved. What is the difficulty level of the tooth? Actually, it comes back to our skill only. If the difficulty level is good, and if the difficulty level of the tooth case is high and we know that we can tackle that, then go ahead with it. Otherwise, it's no shame in taking advice or help from a colleague of ours, armamentarium, how much we have. So it's a basic chart umbrella that helps us in a creating a treatment plan and planning for our patient, because it is beneficial for him, right? And for us to provide a quality of the root canal treatment or the treatment, whatever we are doing. Again, I'm emphasizing on the fact that endodontic mishaps are not the reason, procedural errors are not the reason of direct reason of causing an endodontic failure, but they just prevent the control and prevention of the intracanal endodontic infection, because we are not able to clean and shape effectively and create a microorganism free, or I would say not a microorganism free, but environment which has less microorganisms and which doesn't have strength to create microbial infection, so we are not able to create that environment. So it's better we change our perspective of seeing endodontic mishap. Even if an instrument fractures, take it as an opportunity to learn how to bypass the instrument. If we do not have instrument retrieval kits, it's a time to learn and struggle to see how it can be bypassed, right? If perforation has happened, it's time for us to learn how MTA can be applied. So take it as an opportunity to go to the next level, right? Interesting study. Pain perception was seen on foraminal enlargement, and conclusion is even interesting here, that they said that foramen enlargement increased the perception of pain only within first 24 hours post-operatively. And also the rate of cases in which filling material extrusion was observed after root canal therapy performed with Wave 1 gold instruments was less. So probably they mean to say that even if we enlarge the apical foramen here, so patient might have post-operative comfort for only 24 hours. So in the end, even if your file goes beyond, in the end, even if there is some material extruded which is biocompatible, bioinert, and if bioactive, very good. Then also there is no harm done. We need to change our thinking, what we feel. Even if your I would say 25 number or 30 number file goes beyond, don't get disheartened. Don't say that apical foramen is broken, I don't know what will happen, and this. Yes, it is in an ideal scenario. We don't want it to happen, but once it has happened, it has happened. Look beyond it, that how we can actually now create an environment where I can get a good apical seal. If you get an apical seal, your job is done, right? Because the story is to get an apical seal. The story is why you are preserving an apical foramen, because you should have a good tuck back, good apical seal, good corneal seal, so that your treatment is a success. So even if you have enlarged the apical foramen by mistake to a number 30, then try to get a good apical seal so that you need not worry about the success of your treatment here. So coming on to the end of the topic here, the take home message basically is it's a very general take home message that every case is important. We all know that, but at the same time, we need to appreciate that patience is the key. Not every case can be done in a hurry. Attention to every detail must be given. We need to give attention to pre-operative radiograph, because pre-operative radiographs are blueprint that tells us the story what we are getting into. S- Sort of story. They don't give us the exact information, but yes, a lot of help we get from pre-operative radiographs. And to be very frank, we do not have the advantage of getting CBCT for every tooth. Let's be very practical. So this is all we have, and we have to make the most of it. Reading the radiograph, question yourself. If you have a colleague that supports you, very good, discuss the case with them. Otherwise, question yourself, think out of the box how it can be done, how you can treat your cases well, how you can improvise on the quality, because improvising on your quality is only it only happens when we question ourselves and we try to improvise on our own mistakes. The day we start thinking that we know the best and we are the best, then that is actually the it starts the end of our probably professional journey, right? Endodontic mishap is not the end. Even if you break an instrument, create a perforation, I'm not saying start doing it now, right? But by any chance, if it happens, don't get disheartened. Take it as an opportunity to learn something new and correct on your own faults, and keep yourself ready for the day. It's a very good idea to see your cases, whatever cases for that particular day are coming, see your cases half an hour before and get ready with them. It takes you to a different confidence level, especially when master students, if you are hearing this presentation, I would say try doing it, right? Because try coming to your cubicle 15 minutes before and try doing it, and you will see the change. You will see the change in first two patients. Your confidence level will be different because you are ready with the armamentarium. You know what it has to be done, and you just are ready to go once the patient comes in. So in the end, I would just like to advise this, that we may not be the king of the jungle, but no one can ever stop us to walk on our chosen path and make our own mark. You know, we don't have a choice to not to walk. We have been given birth by the Almighty, so we have to walk on this terrain of life, right? Up and down, He has to choose, but it's the choice is whether we can walk with the sense of gratitude and no complaints, or we keep on cribbing. In the end, it will only matter to us. Doesn't matter to anybody whether we are cribbing or whether we are crying. It will only matter to us in the long run. So it's always better to choose our own path and walk strongly on that path, and try to help each other and consider it as a teamwork, whatever we are doing. I'm always available on these social medias. You are free to, discuss any case, and you are free to approach me anytime. This is my WhatsApp number on the screen. I will be more than happy to help anybody, especially if somebody is coming from Subharti. It's a home for me, and you all are my family members, so it will be an honor for me to interact with anyone from Subharti, right? Though it is open for the world, but still, Subharti is like my personal home. And again, I would like to thank Vinita ma'am, Nikhil sir, for this wonderful opportunity, and again thank my group of teachers in Subharti, who have really helped me to become something. If not everything, but at least a human being, if I may say, right? So I am really thankful to everybody. Dr. Atul Krishna sir, late Mukti ma'am, and Dynamic CEO Dr. Shailya Raj, Nikhil Srivastav sir, Vinita ma'am, thank you so much for this opportunity, and I would love to come there personally sometimes and take your blessings, each and every one of yours. Thank you so much. Have a nice day.
Thank you. Thank you so much, Dr. Varesh, for throwing some light and sharing your knowledge and experiences on this topic. You've truly showed us that failure is simply the opportunity to begin again and more intelligently. I'm sure all of us must have benefited from it and have gathered many points of clinical interest. And we would definitely love to have you here someday. I would like to add here that due to unavoidable circumstances, Dr. Viresh had not been able to join with us live today, but he would definitely love to answer all your queries. You can mail your questions directly to him on his mail ID. Now, I would request a respected principal, Dr. Nikhil Srivastav sir, to give away the token of appreciation to our esteemed guest speaker and shower his blessings on us.
Thank you very much, Vinesh, for a wonderful lecture. Though it was little long, but I think the delegates must have gained a lot of things out of it. Uh, as I have been telling you all, that it would have been our pleasure to have you here physically and interacted with all of you as we are celebrating 25 years of excellence. But then, because of COVID and certain other circumstances, we couldn't invite you personally. But God willingly, if everything goes right towards the end of this year, we are going to invite all of you come here, and again we would like to hear from you. Thank you very much for a wonderful lecture, and I'm sure that that those who have some queries will be contacting you through head of the conservative department or the faculty of the conservative department, and then they will get the reply. So on behalf of Subharti Dental College, kindly accept this certificate of appreciation for sparing time and delivering this very good lecture. Thank you very much, Videsh. Kindly accept it.
Thank you so much, sir, for your kind words. On behalf of Department of Conservative Dentistry and Endodontics, I would like to thank our guest speaker, Dr. Varesh Chopra, once again for sharing his experiences on retreatment with all of us. We would also like to extend our heartfelt gratitude to Dr. Atul Krishna, sir, and late Dr. Mukti Bhattnagar, ma'am, founder Subharti Group of Institutions, for being the guiding light. Also, we would like to extend a sincere thanks to a young and dynamic CEO, Subharti University, Dr. Shalya Raj, for motivating us to organize such educational events even during COVID times. We would also like to thank our Honorable Vice Chancellor, Subharti University, Dr. V.P. Singh Sir, for his love and support throughout. We extend a sincere and heartfelt gratitude to our Principal and Dean, Dr. Nikhil Srivastava Sir, for always believing in us and pushing us to do better every time. Thank you, sir, with all our hearts for all your support and encouragement throughout the entire event. We would also like to thank Mr. Vishal and Ayush from the Department of Marketing and Communication for smooth and uninterrupted conduction of this online webinar. Last but not the least, I would like to thank our Head of Department, Dr. Vinita Nikhil ma'am, all the faculty members and postgraduates from the Department of Conservative Dentistry and Endodontics for their constant support. In the end, thanks to all the participants, all our alumni for the patient hearing. Jai Hind, stay safe and have a great day.